Here, Henry's going to kick off and talk about lower airway disease. Hopefully in the middle we might have what maybe we think is the most interesting part where the two interact, and then we'll talk a bit about lower airway disease at the end. Henry, you definitely have control of the slides.
Yep. We thought we'd talk mostly and discuss diagnoses today because there's far too much to cover in one session. So we'll talk about some medical treatments, but we're not going to get bogged down in surgical intricacies. I'm going to start really by looking at where we are currently with the best, most sensitive tools for diagnosing respiratory noise particularly. There's obviously lots of signs and symptoms of respiratory disease, but we thought our start point would be abnormal respiratory noise and where that can lead us diagnostically and subsequently. So we're going to talk a little bit about dynamic endoscopy and the pros and cons of it, because it was game changing when we started doing it in terms of the conditions and diseases you could diagnose accurately and therefore inform treatment of those, and how we might interpret noise during exercise, because we've learned quite a lot about that since we've had dynamic endoscopy. And then I'm going to concentrate more on dynamic collapse of the upper airway than other diseases, because this is a real conundrum, and some of the other diseases that make a noise are a lot more clear cut than the multifactorial things that can make the pharynx function poorly during exercise. And we'll touch on a few other ethical points, because they're currently the chat out in the airwaves, even though that may be slightly disproportionate. So dynamic endoscopy started when I was a resident, really, in the 90s, and people invented treadmills, and of course initially you would have imagined that a horse would never actually gallop along a fixed treadmill, but they started in Michigan State and places like that, and they realized that with racehorses they can very easily be trained to a laboratory situation, and on the treadmill you can measure an awful lot of things, a lot more than just their respiratory noise. You can have endoscopy, you can measure sound, you can measure respired gases, so as a laboratory tool it was quite powerful, but obviously it's quite labor intensive. You need a lot of people, you need a very good exercise protocol, you need a building, you need a very expensive treadmill, and some trainers there was a misperception that horses injured their musculoskeletal tissues whilst galloping on the treadmill, which was usually done on an incline of 5 degrees, even though retrospectively there is no evidence whatsoever to back this up, and the injury rate of tendons on treadmills was less than the injury rate of horses in training. Nevertheless, that inspired Sam Franklin to try and look at developing a telemetric system in association with some of the engineering department. And again, it was sort of blue sky thinking, and we'll never get horses to canter around with this box on their head, but they did. And over the years, it's got gradually smaller and smaller. So now it's quite a small box on the side of the head like this one, a semi-rigid scope with telemetric transmission to a screen, so that you can get real-time visualization of what you're seeing, and also recording on the unit to retrospectively review what you're seeing in higher definition. And this has pros and cons. The pros are obviously that it's much more portable, it's much more convenient for the owner in that they don't have to transport the horse. It means that the exercise test can be tailored to what that horse does for a living, and to some extent, in some situations, the test can be tailored to how athletically far you need to push to do it. The disadvantages are, and I think we don't want to forget about these, that it measures an awful lot less than we used to on the treadmill. It basically just gives you a visualization. There is some microphone recording, and if they have an ECG, it can be corresponded with what they're doing at ECG and their respiratory pattern as well. And there are some people that do that, but a lot of people just bung on an overground scope and canter it up a field a bit and think that gives all the answers. So there is quite a lot of tailoring, and you can do a very thorough systemized test, and or you can just bung it on and canter a horse round and pretend that you diagnose something. So there is some expertise in interpretation, in doing a consistent overground test, because obviously it's pretty intrusive for a horse to have this thing shoved up its nose and do its normal thing. And also to be able to interpret what you're seeing. It's not always straightforward, and the more you do, the more you realize there's quite subtle changes in what you're seeing. So I think for clients thinking they need an overground scope, or a dynamic endoscope, as I prefer to call it, they need to just think about who should be doing it, and if they've got, the expertise for their particular sports horse group or whatever, what is a good place to do it, and when to do it. When I say where to do it, obviously more endurance horses need a longer test, so they're better off going around a circular track where the exercise length can be extended longer, whereas others can be done in an indoor school depending on their athletic activity. So these are quite important things to consider. It's not just a kind of plug and play thing to do at any time, any place. When to do it, by that
Yes, Henry, is it worth? I was only going to say, Henry, it's worth mentioning. I guess we've had plenty of discussions about the fact it's quite surprising. We find lots of trainers have quite short gallops, and actually it's really hard in real life to achieve that sometimes.
Yes, definitely. A lot of trainers train on an uphill 5 furlong gallop, and if the horses are fit, that will not expose a lot of dynamic disorders, because they'll have sufficient recovery time between stints. And the best situation is a circular gallop, or a long field where they can gallop to about a mile and do more circuits if necessary. If you've got a horse running upside, that will push them further as well. And if they're being ridden by their own experienced jockey who can report what he hears, I think that's much better as well. For racehorses, this is. The test can be tailored quite a lot for different sports horses, and we'll talk a little bit about that at the moment. And it's very important that the scope is looking at the bit that you want it to see. To see the larynx, the scope needs to be intruded rather further than to see the soft palate. So it may be necessary to repeat the test, readjusting the scope in between tests to see the full upper airway dynamically. And it needs to be straight. Sometimes if they're sent to you and they're upside down or sideways, or there's mucus flying everywhere, it just means the interpretation is less accurate. And the people with the most experience of doing them, as with most things, actually get the most consistently better looking tests. What has improved a lot is that many of the cameras on the video scopes are high definition now, so the image quality is really, really amazing, much better than when we started. So we also do them in indoor schools. This is the complete opposite. And this is a not particularly fit, non-limited athletic ability horse that the owner was concerned was making a noise. And so that's the start point. And obviously there was not much point in trying to get this thing to go fast up an inclined gallop for 5 furlongs, because we may have had to get a cardiologist in to help it afterwards. So, it's not an elite athlete instrument. It's a diagnostic tool that can be applied to any horse that will tolerate having something shoved up its nose. And a bit of history taking before to plan the dynamic endoscopy if necessary to tailor it for that horse is really good. The making an abnormal noise is still one of the reasons a horse that's sold at the racehorse sales can be returned. So great emphasis is placed on abnormal noise. Perhaps, in my opinion, too much emphasis is placed on it, because it doesn't always denote catastrophic airway dysfunction. And at private vetting sales, it's a little bit less clear cut. And it wouldn't be a normal thing to have done a private vetting, I don't think, and I don't think it should be, in the same way that it's become very in vogue to radiograph necks at sales, but often the equipment and the situation to do it doesn't give the best quality results. I think it's an added extra which should be introduced as a separate test, just as an echocardiogram would be, or a specific ophthalmic test. if there is a suspicion at the sales, and it would be terrible if it was thought of as a standard thing, because there isn't the expense, resource, or time to make it a standard thing, and the vast majority of horses wouldn't need it. So, and we do know that dynamic dysfunction is a source of abnormal respiratory noises, and some of Sam's work on the treadmill demonstrated that horses have dynamic dysfunction of their pharyngeal structures do make abnormal noises. So if there is an abnormal noise, there is a strong possibility that it merits further investigation. And when I was doing this test, I think the owner wanted to stop before the horse even did. And that's not uncommon, but that's fine. You can still do something useful. But it brings me to the point that the level of fitness of the horse is very important. And I think horses that have unfit limbs also have unfit pharynx muscles as well. So for the owner to get the best results, a certain level of fitness is helpful, I think. And sometimes the noise will ameliorate when the fitness of the horse improves. So this is just an example of some of the things that cause dynamic pharyngeal collapse. And I put everything that's not the larynx or a specific thing into dynamic pharyngeal collapse. And it can affect different structures differently at different times and at different times of exhaustion during a test. And there are some prodromal signs that the horse knows are precursors to pharyngeal collapse, and they will adjust their work output when they sense those prodromal signs, and we can pick those up dynamically. There's also some effects of posture and fitness and acquired diseases to know about as well. So this is a horse with a fairly symmetrical larynx, but it's a dressage horse. But the dynamic scope is retracted so that we can see the rostral part of the soft palate, and it's very clearly billowing here. And we know that that can make noise, and it does contribute to airway dysfunction and reduced tidal volume, even though this particular horse's larynx, it's not perfect, but it's sufficiently functional that certainly isn't going to impede its minute volume. So pharyngeal palate instability is quite a common sign, and we know that it is significant. It's quite subjective to interpret it, and the more you look at deciding whether something is normal movement or pharyngeal instability can be difficult, but it is certainly notable. And some of the others, grade 4, recurrent laryngeal neuropathy will make an abnormal noise at pretty low levels of exercise intensity, but as the grades decrease, it may be that the respiratory noise only appears as the horse nears exhaustion or the maximal exercise potential. And similarly with these slightly more subtle ones like medial deviation of the aryepiglottic folds, vocal cord collapse, cornicular process deviation, epiglottic retroversion, and prolapse of the tracheal membrane. These all are possible of making abnormal respiratory noises. They can occur singly or in virtually any combination as well. And that's why doing a thorough test and reviewing the video several times means that you've got a much better chance of diagnosing them. I just thought I'd very briefly mention stridor at rest. We're not going to dwell on this too much, but if a horse is making stridor at rest, it's clearly got something very seriously wrong with it, and it's not necessary to do a dynamic scope used to diagnose these. They're most commonly associated with vagal damage, or which can be as a result of guttural pouch mycosis, or things like lead toxicity and hepatic disease. And we do very occasionally get spontaneous bilateral laryngeal paralysis as a consequence of acute respiratory obstruction. They will try too hard to breathe against a closed glottis, and that can damage the muscles or the nerves irreparably in some cases and cause them to have very severe respiratory denoise at rest. So linking towards the overlap with lower respiratory disease noise, we do know from some of Emmanuel's work that respiratory viruses do have a significant effect on athletic respiratory performance. And if there is lower airway disease, these horses can produce respiratory noise as well. And even if they don't produce a noise, there is merit in doing dynamic endoscopic evaluations to assess their function, because mucus flow and things like that sometimes only diagnosed dynamically. Um, and even at the lunge as well, I think if some horses move more freely at the lunge, and it can be quite helpful to look at postural things at the lunge when they're moving freely prior to looking at them in harness. And we know that race horses race with their neck extended, so it's pretty straightforward. They always race in the same position and they're going flat out. But in sport disciplines and leisure horses, there's all kinds of head postures that are fashionable to win prizes, and these do have an effect. And the posture is very important. We know that pole flexion causes flaccidity in the rostral soft palate by relaxing the palatinus and palatopharyngeus muscle. And you can see this horse is its normal competition stance. It's entirely different from the posture of the racehorse. And many of these will make a respiratory noise due to the posture that they're being asked to work in. But this is not usually athletic limiting. And so it's more of a problem for being judged by dressage judges rather than affecting the athletic performance of the horse, which can usually be improved by letting go of the reins a bit and letting it assume a slightly more natural posture. And for some of these disciplines, dressage horses and things, we've got to try and get a compromise that's acceptable to the rider and the judges, but still allows the horse to function physiologically. So I'm not going to talk about surgical treatments today. We'll just talk about, I'll introduce medical treatments, and then obviously Sarah will have lots of comments on these as she will titrate the specific treatments more for an individual horse. But for many of these diseases of the pharynx, the dynamic diseases, there is a suspicion that they're a consequence of inflammation, and which may be to the muscles or to the nerves in early life. And I see most of these really as medical diseases. Surgery is not usually an effective treatment of muscle disease. So I think these should be investigated and exhausted in many of these cases before considering the surgery options, even though the default and the habit has been, particularly in racehorses, to think of a surgical solution immediately. But there are ones that will respond better to medical treatment and possibly don't need surgery. And an example would be this one, which has epiglottic entrapment, which results in hyperplasia and thickening of the subepiglottic folder that entraps the epiglottis. And I would always advise treating these medically to reduce the inflammation before surgery. It makes them more straightforward surgery candidates, and they respond quicker to it. And some of them actually therefore don't require surgery. And if you have this, this will predispose to this, which is DDSP. But unless you examine them with the epiglottis in its normal space, you might assume this is just persistent DDSP and be unaware that actually that's a secondary consequence of the dysfunction of the epiglottis hooking over the free border. So, Sarah, chip in there. I think I don't have too many more slides. I've got one on the ethics of airway surgery, and
I guess.
yeah.
Oh yeah, should we talk a bit more about managing the upper airway stuff first, and then talk about the and the kind of medical stuff? Because I guess one thing
Yeah.
I feel like we do and definitely talk about quite a lot is also, I guess this stuff, all the anti-inflammatory stuff is a kind of acute thing to try and dampen down whatever's going on, whatever might have driven these things. But I guess the other thing that we sometimes get into with these horses, and I guess in my mind, a particular sort of demographic of dressage horses and maybe cobs as well, is trying to help them strengthen the pharyngeal muscles. I guess, I don't know, Henry, whether you think that we engage in hocus pocus at this stage, but we have a like protocol of various things to do with kind of, I mean, basically trying to strengthen the pharyngeal muscles in the same way you'd work out any other muscle, which involves lots of different things to try and make them move their heads around, basically. Various
Yeah.
exercises like when they're being ridden on and off the bit and stuff, and then things in the stable with stuff dangling from the stable roof and things to try and strengthen the muscle. I mean, I don't have any evidence that it works other than for plenty of anecdote. But I guess I was like to feel, I don't know, Henry, whether it's worth talking about Laura Fitzharris's
Yes. I mean, there
PhD
is some
on this
evidence that that respiratory muscle training does have benefits. Laura and Kate transposed some techniques used in humans with chronic airway disease by training some horses to resistance breathe, which basically means breathing through a small tube, and increasing the work done by the diaphragm and also the respiratory muscles to respire adequately doing that. And they did it in a relatively small number of trainers because obviously compliance is a problem, but the results were significant. And well, I don't know if they were significant statistically, so that's the wrong word, but they were very interesting in that the horse's respiratory performance did improve following a certain period of training. It was done regularly on a daily basis. And if you cease treatment, then there is a tendency for the muscles to lose their fitness, if you like. So I think this got as great potential. I definitely think this is the way forward. We just have to find a way of achieving it practically that that we can bring clients on board with that's acceptable. Because as it is at the moment, an expensive mask is necessary, and the risk of getting good compliance is pretty low, unfortunately. So I think it's got good potential, and I think you know, in some of these that will be all that's necessary if we can find out a way to do it, training the external muscles as well as the intrinsic ones.
And Henry, is it fair to say the opposite is probably true, that allowing horses to continue to train that have some dynamic instability without doing anything to address it could potentially also be making the problem worse?
I think that is a harder one to answer. I think for things like DDSP, there are so many factors, and it's not just the performance of the particular muscles involved in maintaining the palate. The character of the horse, how determined it is to win, the ground it's going on. I think all of these play into whether or not it happens. And there are horses that learn to feel when it's about to displace and stop trying. So I think there's absolutely no point flogging them on soft ground if they persistently displace. It's not going to get any better. And actually, yes, backing off to reconfigure that horse's individual training and probably when it competes, it again is a way of dodging the problem, really.
And I guess we definitely see in kind of sports horses or maybe pleasure horses that have this more sort of complete pharyngeal collapse in every direction, that they seem to get a bit panicky, which I suppose, given how they look endoscopically, sometimes isn't that surprising. And they definitely seem to get a bit panicky and sort of back off from trying, and the owners perceive them to become a bit lazy.
Yeah, I think those ones are very tricky as well because we haven't really found anything that consistently works. And change of career is one option. And I do think some of those benefit from being allowed to ride in a completely free posture to just get the confidence of having a non-concertinaed up airway so that they feel like they can breathe better, and then escalating it. And we really don't know why. There have been some histological studies on these pharyngeal muscles that appear to be dysfunctional, but they haven't really yielded conclusive results of an actual pathology. But there are horses that seem to have incredibly flaccid pharynxes that can't maintain tone in the changes of pressure. And it does seem to be an acquired thing because horses that used to be able to do it then acquire these syndromes. But as we said, we've not had much success with those other than anything else. So experimenting with training regimes seems pretty sensible to me.
Yeah, definitely. And so, yeah, I guess yeah, we would have some anecdotes of some of those that go well, but equally plenty that don't go terribly well. Cool. Should we continue on and talk about ethics?
Yeah, so I'm not going to mention this too long. If we do another one on surgical treatments, I think it becomes more of a moot point. But Kate did some work. Kate Allen at Bristol did some work looking at ethics of the perception of ethics in sport horses, and two of the things that concerned the stakeholders, and they were veterinarians who responded to it, that concerned the most were multiple joint injections and airway surgeries, and so there is a perception that it may be done more than necessary and unjustifiably, and there are possibly some welfare concerns about that, and I think there's no more logic to scrutinize the ethics of that particular branch of surgery more than any other branch of veterinary medicine, really. There are sort of justifications that should be applied equally across the board to horses in competition. But it's very fashionable, and because, there is an awareness of it, it should not be ignored. But I think if the treatments are done preceded by an accurate and as specific a diagnosis as possible, then offering and undertaking the best treatments available is perfectly reasonable. And ideally, the tailors a treatment to the problem that's been diagnosed rather than a slightly more broad approach, which has historically been fashionable in some places. But I think, you've got to consider some other surgical or medical treatments, such as joint medication, back surgeries, no differently than this, really. And you could say, yeah, there's quite a lot of things as veterinarians we do with a pretty poor base of evidence. And we do have to consider, is is this straying into the red zone with animal welfare? Is it okay? Because if it wasn't able to compete, the animal would have a worse life. And it's certainly not black and white anyway. But I think if there's informed consent and clarity, and evidence-based treatments are done following a diagnosis, then it's a reasonably robust position for a veterinarian to take. And it may be that there'll be some legislation demanding more objective data. And we do need more research on the efficacy of quite a lot of the procedures we do, but that certainly isn't just respiratory tract surgery. Okay.
Henry, there was a question maybe just before we move on. Julie was asking, in the medical treatment section, you talked about using meloxicam. Do you think you get better results with meloxicam than other non-steroidals?
Um, I don't know, to be honest. The recommended dose of meloxicam that is licensed is quite a low dose, and you can use it a higher dose with a more analgesic effect, I certainly believe. It has a fairly short with detection time as well, so that is one of the reasons it's a popular alternative to some of the other non-steroidals. I think we should just consider things other than phenylbutazone. Not that I've got anything against phenylbutazone. It stood the test of time and is a very good analgesic, but we shouldn't immediately discount some of the others that might be more sparing or subtle as a result.
Great. Super. Shall we move on to some lower airway things?
Yeah.
So I was just gonna go, we'll see how far we get through this, but the rough plan was to talk about just BAL technique a little bit. Then we're going to talk a bit about mast cells. I think they get forgotten from time to time. We'll talk a little bit about asthma treatment and summer pasture-associated asthma, which seems to be particularly bad this year. And then just a plug for the old consensus statement. Henry, please, can you do the slides? I don't think I can. I'll check.
No, just say when you want to move on.
Thank you. So I just thought we talk a bit about BAL technique. Partly because depending on people's enthusiasm and reading and things, they may have come across this literature about bilateral BAL. So from the beginning, really, should we use a tube or an endoscope? I really have no preference at all. And to be honest, in the hospital, we do either without particular excitement. The only thing about the endoscope I would say is it must have been sterilized or disinfected. So if you want to use the scope, if you want to use, and you need to use a gastroscope, it needs to either have gone through the gas or at least have been in the cold sterilizing. But I would say definitely for it to be going through the gas intermittently if you're going to start using it for BALs, because obviously endoscopes love to grow Pseudomonas, and you do not want to be instilling large quantities of Pseudomonas into the lower lung fields. So then this paper that came from France, and actually there was a similar but paper preceding it also from French authors, looked at whether we should be sampling both lungs. So they used, obviously you need to use the endoscope if you're going to do this. The sort of headline results are very exciting and sort of suggest, oh, the two different lungs are different. But if you actually dig into the details a little bit, they were only looking at cases with really mild disease, and the outcome in terms of sort of binary diagnosis was only different in a very small number of cases. So the conclusion actually really is that for most cases in practice, it's not going to be necessary to do both sides. if you had a very complicated case that wasn't doing well, or you were suspicious about your, I guess, for example, if you had a case that you were really sure that was the problem, but your blind BAL came back with no exciting findings, you could go back and scope and do both sides. The one thing I would say is not to get excited about this technique in horses that have got more severe clinical signs. So certainly in horses that have got severe asthma, I personally steer away from doing both sides. I have had a couple of cases which did both turn out to have interstitial pneumonia, where the effect of instilling 250 mils of saline into both lung fields was very dramatic and unpleasant. So personally for me, it's definitely a technique to be kept for mild cases, and only probably mild cases where you feel things are complicated or not going the way you want. The other literature that's relatively recent and might be useful for BAL technique is whether you use bronchodilators beforehand. So the papers used pre-treatment with salbutamol given with an spacer. And they did increase the amount of fluid they got back from about 40, just less than 40% to about 50%. And they probably actually, what I thought was most interesting was it was easier to recover the fluid. So you didn't need to apply so much suction to get the fluid back, which has potentially positive effects. I mean, most people manage to BL most of the time without any kind of traumatic effect, but I guess sometimes your last sample starts to look a bit red tinged. And you probably have at that point applied too much force, so it certainly would help to avoid that. So I think that can be useful. And again, I think that's definitely useful in horses that have got more severe clinical signs. I think then, again, you potentially can pre-treat with salbutamol to try and avoid any nasty transient complications from your BAL. Henry, next slide, please. So I thought we'd just talk briefly about BAL interpretation. Really, because this stuff came from the consensus statement, which is actually now really old. It's nearly 10 years old, but it's still probably one of the best things out there in terms of thinking about asthma in a sort of cohesive review article type way. So they just talked about the sort of old-fashioned restrictive view of BAL interpretation would be that more than 5% neutrophils, 2% mast cells, and 1% eosinophils would be considered abnormal. But they propose a sort of alternative, slightly more relaxed viewpoint that maybe 10% neutrophils, 5% mast cells, and 5% eosinophils is more realistic. Although interestingly, there is also literature to support the fact that horses that chronically have more than 5% neutrophils present do have histological changes visible. So those horses definitely are abnormal. But I think this information is maybe useful in terms of interpreting your BAL in terms of your clinical picture. If you have a horse with very convincing clinical signs of poor performance and 6% neutrophils on a BAL, I guess you're going to have to interpret all of this in light of your clinical findings. But I guess at that point, it maybe raises the question, is this really exciting? Maybe it's going to be a bit like mild gastric ulcers. Maybe you'll have to treat it to find out. But I'd be certainly counseling the owner, hang on, this is not that exciting. Maybe we need to be looking for something else here. Yep. Next slide, please, Henry. So that brings us on to the mast cell discussion, probably. Mast cells, I would say, are definitely an under-recognized cause of mild to moderate asthma. So, yeah, these are the horses. Formerly, this would have been called inflammatory airway disease. These days, it's called mild asthma. They, for me, are definitely cases where there's a reason to do a BAL because you are not going to see these mast cells on a track wash. I'm sorry, it's covering my slide. So you definitely need a BAL to look for these mast cells. Then again, we talk about this interpretation that we were just talking about, whether, technically more than 2% is abnormal. I think we definitely get excited when there's more than 5%. What you do with those horses in the middle is a bit more of a tricky issue. But I thought I'd just put an example in. This horse came in last week. He's a 12-year-old sports horse. So his main clinical sign was that after exercise, he was performing less well during his exercise, but afterwards he had a really severely increased respiratory rate and effort that then took a long time to recover. He came actually predominantly initially because he had also a grade 3 out of 6 hollow systolic heart murmur. That turned out to be just an incidental finding. and the respiratory signs were more exciting. So we did a track wash and BAL on him, and I thought it was kind of useful just to put the results up here, bottom right. His track wash had 14% neutrophils, not very many mast cells, and no eosinophils. So if you did just a track wash in this horse, you'd think, fine, nothing exciting going on here. But the BAL had 5% neutrophils, again, not exciting, but it did have 8% mast cells. And I think it might be relatively easy to gloss over that, but actually, that's quite exciting. This horse does have mild asthma or inflammatory airway disease being driven by those mast cells, and that's what's causing the airway hyper-responsiveness or hyperreactivity. He's got these spasmy airways, and that's why you see the clinical signs that you do. And if you can address that, then you'll make really good progress, hopefully, with this horse clinically. Next slide, please, Henry. Next, I just wanted to talk a little bit about treatment of more severe asthma. Now, if you move on to thinking about severe asthma, so these horses that have got clinical signs at rest, they're often older, teenage, late teenage, or early 20s horses. We see these horses in the winter with their signs of severe asthma. They're coughing at rest, they may be coughing up snot. And I think this may be a bit controversial, and actually I'm afraid at this point we are heading well away from the literature, just into my own experiences. But I think maybe in these cases we've got a bit carried away with using nebulizers. I am not anti-nebulizers at all. I think they're great and they definitely have a place. But in these horses at the very beginning, when they've got really severe clinical signs, some of these horses then get put on nebulizers, and then the owners are working away at these horses for ages, and they get a really slow or slightly rubbish response. And I mean, why is that? I think a lot of it probably is to do with these horses with severe asthma have neutrophilic inflammation. Their airways are full of snot, and that is going to severely impede the absorption of the nebulized medication, and or just trap the medication in the snot on the way down the trachea. The reason I guess this is important to think about is because I think it definitely prolongs the recovery of these horses, which can at times increase the cost to the owner massively. And also, if the treatment is really slowed down, which it is occasionally in cases, we sometimes see cases where this has been going on for months. Those horses, we know that fibrosis develops with untreated long-term neutrophilic inflammation in these horses. So it does potentially have some detrimental effect for the horse as well. So I just think in these severe asthma cases, probably it pays to go in hard at the beginning. If the horse, from an endocrine point of view, looks like it can tolerate it, then I would definitely go for systemic steroids. Prednisolone or dexamethasone. If the horse can't tolerate systemic steroids, you don't think from an endocrine point of view. I am also a big fan of the Acervo Equihaler. Boehringer have not in any way endorsed this evening or sponsored us, but the Acervo does work very well if you can get the gadget into the horse. The drug inside and the delivery mechanism does mean it works. I don't have any evidence for this, but I would say anecdotally better than the nebulizer. So that would be, I would sometimes in these horses do an initial treatment with the Acervo, followed, and then move on to using the nebulizer. How long are we doing these systemic steroids or the Acervo or whatever? I would say I would like the horse to be looking clinically normal or pretty normal at rest. And sometimes that'll take a couple of weeks. And then you can move on to inhaled or nebulized therapy for the more sort of maintenance type part of this, where you're just trying to carry on dampening things down, and or get that horse through the rest of the winter, whatever's required there. But that certainly is something that we would see these horses relatively often that have been having nebulized medication for quite a long time with a fairly poor response. So I think that's definitely something that's worth considering.
Sarah, can I just ask,
Yeah.
so when do you think that a tracheal wash is not adequate?
Oh,
A
so
tracheal wash alone, I should say.
I think for mild asthma cases, so these inflammatory airway cases, so for horses that only have clinical signs at exercise, and I guess at this point I'm talking about sports horses, I think non-thoroughbreds, I think they all should be having a BAL. For horses with severe asthma, where they've got clinical signs obvious at rest, I think actually, in a way, you can often get away more easily in those horses with just a track wash, because you're just looking for really pronounced airway neutrophilia. and so if people are desperate financially, or if you have some clinical reason not to do a BAL, then I think it's easier in that situation not to do a BAL. I guess that case I showed you just now, you wouldn't have picked those mast cells up on a track wash. So for those mild cases, I think the track wash really is, the BAL really is important. Race horses are a whole different ball game, and I think persuading trainers to do a BAL is a completely different kettle of fish that's probably way beyond the scope of this evening. I mean, there are some trainers doing them, but the vast majority are not. And
I think also, as Emmanuel shown as well, with a lot of the horses in training, you have a knowledge of what the normal cytology is of that horse. So you're looking for changes of that horse's cytology versus its own normals, not comparing them with the horse population as a whole. So subtle changes in cytology can be relevant in those horses because you've got a baseline of its tracheal wash. So I think they probably have a place there, but yeah, it's not very sensitive as just a random test on a one-off, is it?
yeah, and I think definitely sort of track washing and holding the sample up to the light and stuff, I think is pretty rogue these days. Probably cytology is pretty easy. Um, uh, summer pasture-associated asthma, I thought this was worth a mention. It seems to be particularly severe. Well, we've seen cases that have been more severe this year, and I think we've also seen more cases. And this would mirror what's seen in human asthma cases. People who have asthma associated with pollen or hay fever report that it's been worse this year and possibly last year. So I think that's worth noting. Again, these horses again probably warrant a BAL just to be sure of your diagnosis, and also probably in these also to be sure of cell type. So again, cell type on your BAL is going to influence your treatment choice a bit. So again, it's useful information. These horses, though, I think warrant pretty aggressive corticosteroid treatment. If they've got lots of mast cells, then you're going to go for some sodium chromoglycate as well, but that's where the BAL comes in. We do omega-3 supplementation. We're not huge fans of supplements most of the time, but omega supplementation has got pretty good evidence behind it that it's anti-inflammatory. So it's certainly useful to try in these horses. Antihistamines, we're in the realms of evidenceless medicine here. There's no evidence that antihistamine work in these cases, predominantly because, well, but they are really effective in people, which is why it's tempting to try them. But then the pathophysiology of human asthma and horse asthma is not that similar, so it's hard to know how much crossover there is. I guess these cases are often quite difficult cases, and they are cases that's going to recur year after year, so it's worth trying. So we definitely always try antihistamine. I would be cautious about the dose. Certainly, used at the upper end of the dose, they definitely can have sedative effects. And I think that's probably cumulative with time. So if these horses have been giving antihistamine every day for long periods of time, we definitely see a sedative effect in them, which then has an impact, obviously, when it comes to performance. So just be a bit careful with that. Environmental control is much more challenging than it is for sort of classical winter asthma. Can you keep these horses housed all the time? I don't know. It's difficult. Putting Vaseline around their nostrils, does it work? I don't know. It feels nice. So we'd normally suggest smearing their nostrils with Vaseline on the inside before you turn them out or before you exercise them, and then wipe it off when they come in the hope that you catch lots of the pollen and wipe it away. And with the same, I mean, in really severely affected horses, you can bathe them when they come in from the field in the hope that you reduce the period of the day that they're exposed to the pollen for. And then the last thing I put up there is immunotherapy. There is very little evidence either for or against use of immunotherapy in horses with asthma. But these summer pasture-associated asthma cases are definitely ones where I think maybe it's worth considering, just because we have so few other options. Next slide, please, Henry. So I put this up. I wasn't sure if we would get to this. And if people have questions about other topics, please do type them in the box and we'll try and address them. I think there's plenty more we could talk about with asthma, but I wasn't really sure where people wanted to take it. I thought I'd just put this paper in because I think this is still something we see quite a lot. And I thought it was interesting to discuss. So this paper it was a survey. They did a survey of 250 vets across 25 countries. And they found that 50% of the vets they surveyed sometimes prescribed antibiotics for asthma cases. At the risk of telling you something you definitely all know, asthma is a non-infectious condition. So the asthma itself definitely never requires antibiotic treatment. Do they get secondary infection? Yeah, of course, it's possible. It's definitely possible. It definitely happens in people. It happens in horses. Does it happen often? I don't think so. What clinical signs would make us worried they've got secondary infection? Again, I think this is probably something everybody knows. Fever, inappetence, dullness, real signs of infection. And your track wash, frequent intracellular bacteria are the kind of hallmark of infection. But if you're going to go down that road of track wash and looking for intracellular bacteria, you have to be making fresh slides at the time that you take your samples. If you take a track wash and bung it in a pot and bung it in the post, the neutrophils are still active. So they'll be tootling around in the pot, munching up the bacteria that even can just be pharyngeal contamination for the process of the track wash. So I am religious, I'm afraid, about making fresh smears of your track wash or your BAL at the time of sampling. I think you get way more useful information out of it, and the pathologist can just interpret it much more easily. Otherwise, if they have these samples that mostly look like a horse that's just got asthma, but then there's quite a few intracellular bacteria, they're left in this sort of quandary where it's pretty hard for them to interpret. So for me, that's a real, really, really useful thing to be doing. When does it not warrant antibiotic use? So if you've got a positive bacterial culture, but none of the other things we've just discussed, that's just because track wash samples aren't sterile. So I think culturing track washes is actually a bit of a minefield. Obviously, you should do it if you think the horse has a respiratory tract infection. If the horse has pneumonia, culture away. But if you think the horse has asthma, why are you requesting a culture? I guess we sometimes would store ours and then ask for culture if the cytology is different to what we're expecting. I think we definitely wouldn't routinely culture a track wash from a horse with asthma because hopefully you're not going to ever need that information. And also horses that don't respond well to your initial asthma treatment, it doesn't mean they don't have asthma. It just, not necessarily, as long as you're confident in your initial diagnosis, it just means the treatment hasn't worked and we need to reconsider the treatment as long as you were confident about your initial diagnosis. So I hope that's not, I don't know, I feel like it's easy to get on a bit of a rant about this topic, but I think it's just something that's really important to consider. I think we're all trying to be more responsible with our antimicrobial use, and I think this is definitely a topic where it's easy to fall off the wagon a little bit. And then I think the next one, Henry, actually is my last slide. We've romped through that fairly quickly. I thought I'd just put up a few things. If anyone wants to do more reading on this topic, the consensus statement from ACVIM, as I said, it's nearly 10 years old, but it is just a really nice summary of the sort of central points about asthma and how the diagnosis, lots of really nice information about the diagnostics and about interpretation of your samples and things, which I think is really useful. They talk quite a lot about treatment as well, and actually they do also what I guess we haven't addressed at all, and actually in my little antimicrobial section there I didn't really address asthma in not asthma, airway disease in racehorses, which I think is an entirely separate entity, minefield, which we can definitely talk about if there's anyone in the audience doing racehorse work who wants to discuss it. The bottom left paper from Laurent Coutil's group is much more recent. It's a bit more, it's a slightly heavier read, I guess I would say. The ACVM consensus statement is really nicely presented, but that more recent paper is obviously a bit more up to date. And then I put a link to the antimicrobial prescription thing if anyone wants to read it. Has anyone got any questions? Interesting asthma cases. Julie says, have you been able to source the Acervo hailers recently under the impression they've been discontinued? I don't think so. We've had them. We definitely ordered some recently. In fact, I mean, again, I'm not being paid by Boehringer, but they were on offer recently. So yeah, as far as I know, they're fine. Actually, the other thing I did mean to say at the beginning of this talk, which I didn't, is that my discussion of medication here was entirely off license. Obviously, it's up to you guys to interpret the licensing laws as you wish, but I'd say that almost everything we do managing asthma cases is off license because just because the way things are licensed or they're not licensed. Even the servo, I'm afraid we would generally use quite often outside of its actual licensed plan.
So I've got a question, Sarah, just to finish off, and you can retort with one of me. If you could legislate, what would be the next development in standard best practice for people out in primary care practice to get into a really good habit to be more sensitive and accurate in diagnosing lower airway disease? What do you think would be the next thing to become like the standard way of doing it that's slightly more scientific or better, but also doable in a practice setting?
Interesting. That's a good question. I guess if I was being economical and I saw a horse with lower airway disease or a horse I was suspicious of lower airway disease. Oh, this is hard because I guess is this a poor performance case or a horse with severe asthma? If it's a poor performance case and I had limited money, I would always go for a BAL and a blood profile. I think that gets you the most information with the least money.
Yeah, I think that's a very helpful answer.
Henry, I was going to ask you, we were talking briefly about this in the office the other day, but I think it'd be interesting to talk about. How do you feel about the nerve transplant surgery for laryngeal dysfunction, 10 or however many years on we are? I feel like when it first was developed, everyone was so excited about it. I honestly thought it was the best thing, the coolest thing ever. And these days I feel a bit like, meh. There aren't cases that
That's a
it's
good
actually suitable.
question. I got excited about it about 20 years ago, even when it first appeared, and thought, great, this is going to end all the complications that we suffer. I think it still has potential. I think it's much more physiological, but I think we're going to have to work at it and be very careful about case selection and expectation management, really. It's never going to be an instant quick fix. So that might mean it's never going to be attractive to the flat racing population, particularly. But I think in restoring normal physiological function to a neurologically deficit animal, then I think, it's got a lot going for it, and we will get better at it. That can be done standing now in many cases. And I think the key is case selection, is doing those horses. There needs to be some musculature to re-innovate. And then there is a period of time of retraining the re-innovated muscle to get some degree of function, but it's not going to function as well as unaffected wild type muscle. So I think we're realistic about that. I think it's good to have another option. But yeah, it's there's still the amount of research on it has slowed a bit after being saturation bombed with money for about 10 years. And it's I don't think it's going to solve the problem of RLN in racehorses, put it that way, which is hugely disappointing, but it's probably realistic, and probably breeding the disease out of the population would probably be a much more sensible approach to it long term.
And you said it's about case selection. What would be the perfect case for a nerve graft?
So the people doing it in a experimental situation have the luxury of being able to do transesophageal ultrasonography, and that can quite accurately measure if there's any atrophy of the cricoretinoideus muscles. You can do that transcutaneously with ultrasound, but it's not quite as sensitive. So you can pick cases where there's fairly severe disease, but the more subtle ones, less so. So the cases to select are ones that have got definite signs of disease, but they have some innervation to the muscle that is affected, and you're catching them at quite an early stage before those muscles atrophy so much that regeneration of the nerve supply to them has got limited myocytes to work on. So young sport horses, before they go into competition, that are mild to moderately affected by RLN, are the best candidates, and those are the ones where there has been actual success with the horses that have gone on to compete at a reasonably good level with satisfactory laryngeal function, and their larynxes are not being asked to perform in the same way that racehorses are.
Cool. Interesting.
But we could have another whole ings about treatment maybe one time if it's fashionable. So if anyone has any suggestions for more topics, we'd love to hear about them. Because they're just they're potted discussions about things which hopefully throw up more questions than answers.
Super. Well, thank you everyone for joining us. Hopefully it's been useful, and hopefully we'll see you all soon.
Yep, thanks for coming, and thank you, Sarah. And we will wait and see what is next on people's appetites.
Yes.